Good to see you. Good afternoon, everybody. I'm really happy to be here with you. For those I don't know, I'm Helen Shea, the Dean of the Medical School. I apologize for my voice. I want to welcome you all today to our Solomont speaker series in conversation with Dr. Hanna, or as she is more commonly known, Dr. Mona. And a very special welcome to all of you joining us virtually, including our main track students and those tuning in from afar. It's really wonderful to have so many members of our Tufts community together today. This event is hosted jointly by the School of Medicine and the Tisch College of Civic Life, and it's a special part of the Common Book Program. Now in its 13th year, the Common Book Program chooses one book related to medicine and civic life and gifts it to all incoming MD students to engage with in their coaching groups and other year-long programming. This year's selection was Dr. Mona's widely acclaimed and New York Times 100 Most Notable Book, What the Eyes Don't See, a story of crisis, resistance, and hope in an American city. If you haven't read the book, I highly recommend it. You can purchase a copy at the reception that will immediately follow this event in room 114 over there. And I hope all of you will join us for light refreshments, mingling the opportunity to get your book signed by Dr. Mona. Although the Common Book is part of the MD curriculum, we're excited to welcome so many of our health science students to this important conversation. The Masters in Public Health program partnered with Tisch College for a special MPH book club reading of this book. And we're excited for many of our collaborations with Tisch to connect all of our students to important civic life and public health issues. And I'll add that the time has never been greater for this partnership between civic life and public health. Dr. Mona is Associate Dean for Public Health and the C.S. Mott Endowed Professor of Public Health at Michigan State University College of Human Medicine. She's also the founding director of the Pediatric Public Health Initiative, an innovative partnership of MSU and Hurley Children's Hospital in Flint, Michigan. A pediatrician, scientist, activist, and author, Dr. Mona was named one of Time Magazine's 100 most influential people in the world and recognized as one of USA Today's Women of the Century for her role in uncovering the Flint water crisis and leading recovery efforts. She's also reimagining how society can come together to eliminate infant poverty with a first-in-the-nation program, RX Kids. Dr. Mona has testified multiple times before Congress, lectures at dozens of colleges and universities, and frequently contributes to national media outlets championing the cause of children in Flint and beyond. She wrote extensively about her experiences in her book, What the Eyes Don't See, a story of crisis, resistance, and hope in an American city. With concentrations in environmental health and health policy, Dr. Mona received her bachelor's degree and master's of public health degrees from the University of Michigan. She later completed her medical degree from Michigan State University College of Human Medicine and her residency and chief residency at Children's Hospital of Michigan in Detroit. In conversation today with Dr. Mona is Dr. Margie Skier. Dr. Skier is interim chief and the Wiener-Haley Family Professor at Tufts University School of Medicine's Public Health and Community Medicine Department. Her research focuses on family engagement and the role that family meals play in adolescent risk prevention. Dr. Skier has been the principal investigator on multiple studies to develop and test interventions related to adolescent substance use prevention. These include a substance use preventative intervention geared towards parents of 5th to 7th grade students in the Boston Public Schools, funded by the National Institute of Drug Abuse, and a study in rural Idaho to develop a methamphetamine use prevention communication intervention for teens, funded by the DentaQuest Foundation. She has also conducted qualitative research with parents, guardians, and children on perspectives around marijuana as the recreational law takes effect here in Massachusetts. Beyond research and academia, Dr. Skier is engaged in community substance use prevention. She's an active member in a local substance abuse prevention coalition, where she gives talks in her town and serves as a subject matter expert to the coalition steering committee. Before I welcome our speakers, I just want to say something to the students here. I think the example that you're going to hear about today is really important as a lesson in why learning about observation, asking questions, and listening is such an important part of your education, whether you're studying medicine, public health, or basic science. You are getting the tools that you need to do things like what Dr. Mona has done and what you're going to hear about today. So I hope you feel very empowered by this conversation. Please welcome me now, joining Dr. Mona and Dr. Margis here. Welcome.
Thank you so much, Dean Boucher. Hi, everyone. It's so good to be here. It is great to be here. Who's got cough drops for the dean? We're so happy to be here. We've gotten a chance to get to know each other. We're really close after 5 minutes. So lots of hugs. Yeah, we've got lots of hugs going on. And we're just really happy to be here to talk about this incredible novel, this nonfiction, which really read like a fictional story. Unfortunately, it was not, but what an honor to have you here. Thank you for joining us. I have some questions for you, and then we're going to open it to everybody toward the end. So hold your questions for the end, but please keep them because we want to hear from you and know what kind of questions you have. So we have Dr. Mona, who is an unbelievable mix of pediatrician, advocate, public health, fierce woman, doing so much to sort of help the lives of those in Flint and beyond. I mean, now your work is just everywhere, and I know that the work that you've done so fiercely has opened doors to continue to do work. So I'm just going to ask you some questions, and we'll go from there. So I have a background in clinical social work as well as public health, and I find that I'm constantly using both of these lenses in my work. And as my experiences with individuals really inform my work in communities and populations and vice versa. And what the eyes don't see is a powerful example of the intersection between medicine and public health, including surveillance, epidemiology, intervention. And at Tufts, public health is really infused into the curriculum. So the first 3 weeks of the medical school program, public health is taught through public health faculties. We have MD, MPH, NPA, MPH programs. And public health students are also interested in medicine or even how to work closely with clinicians. Can you talk about the importance of this intersection in your discovery in Flint and how you continue to integrate it into your work today?
Yeah, that's a great question, and it's great to be here with all of you. Thank you for the warm welcome and the hospitality. I can't wait to hear from you all during our discussion. So once again, please hold on to those questions and comments. So I love being a pediatrician. I love it. I was in clinic all day yesterday, and kids, spit up on me and threw up on me and coughed on me, and it was joy. Every single kid was verbal. Like I asked them what they want to be when they grow up, and you hear the most awesome things. Like I want to be a guitar playing weatherman the other day. Yesterday, I have a 4-year-old who said she wanted to be a doctor. I thought it was amazing. Yes, win. And a 4-year-old a couple weeks ago, I'm like, what? They're for their well child pickup. And I'm like, well, what do you want to do when you grow up? And the little kid's like, I want to be 5. It's amazing. It's joyful work. I love being a pediatrician. I love that one-on-one that I have with children and families, and that role, this privileged role that I have to improve their health. But shortly after becoming a pediatrician, I got really frustrated. I'm like, wait a minute, like why am I taking care of a kid intubated with asthma and we're not addressing air quality? Because there's a zip code by the hospital that has the worst air quality because of all these refineries and like oil plants and different things. And I'm like, why am I taking care of a kid with like a gunshot injury when we're not addressing gun violence? So I kept asking these why questions, and that's what pushed me to go back and get my public health degree in health policy. So I had those other tools in my pocket, those tools of epidemiology and health policy and health economics and biostatistics, all these other things, to do a good job caring for kids. Pediatrics, unlike so many of our other medical specialties, like it's very much about the today. It's about that kid in front of us, right? It's about like making sure we treat their sniffles, which I did a lot of yesterday, and their broken bones and their well child checks. But so much of our work is about tomorrow. It's about making sure kids can be whatever they want to be when they grow up. And we do that through vaccines, through anticipated guidance, through injury prevention, healthy nutrition. All these things are about tomorrow, right? And that very much is public health. That is prevention. And in public health, you get to take care of a whole bunch of people at one time. It's population level work. So in Flint, during the water crisis, like when I realized the potential of lead being in the water, like, I was one doctor in one clinic. And people were like, oh my gosh, well, did you see something in your clinic? Like, was there something, were you seeing more lead levels in your patients? And I would always answer, I'm one doctor in one clinic. I cannot tell you what's happening at a population level. That is why we need to embrace public health and embrace things like surveillance, where we can take a step back and see what's happening to the population of children over time. That is the beauty of what we call surveillance. So it's you guys, what I've heard already you have this amazing curriculum that is embedding so much of public health in medical education. That is so important. We need you to see beyond the patient in front of you. We need you to keep asking why and why and why, and tackle those upstream determinants of health that are impacting not just that person in front of you, the patient in front of you, but really what's happening to patient population level.
Amazing, thank you. Yeah, it is so critical that we do ask those questions. Why is this happening? Not just let's treat what's right in front of us, but we need to get to the root cause. So thank you for that. And speaking of in sort of the same lines, you write about various roadblocks that you encountered in your efforts to reveal what was happening in Flint. And you also raised how so many people could have stopped those roadblocks from happening. But you said that power, money, and other reasons allows these roadblocks to remain. Can you talk about them now and share your advice on how to persevere through roadblocks when you come up against them?
Yeah, I think, that's one of the reasons that I wrote this book, is to share some of these lessons. We were also talking earlier, like I never anticipated to being an author. Like that's not why I went to medical school. Like I went to medical school to be a doctor. But then I never anticipated being at the center of really kind of one of the most emblematic environmental and public health crises of the time. And for a long time, I'm like, there's no way I'm writing a book. Like I just neglected my residents and my work and my children, and like I just uncovered this water crisis. There's no way I'm going to write a book. And then it kind of dawned on me that I have to share these lessons. And there's many, because the story isn't about Flint and it isn't about me, but really it's about all of you, and it's about all of us, and how we do things like persevere, how we communicate science, how we protect a population, how we address inequities, how we think about things like democracy and its intersections of health. So one of the biggest lessons is kind of this ability to persevere, even when there's roadblocks, like in every direction. So when I learned that, our Flint kids had higher lead levels, which was like common sense, there was so much lead in our water. So our water switched, it wasn't treated properly. We had lead in the waters, lead in the water in the hundreds and thousands of parts per billion. So you guys tell me, what's a safe level of lead? Oh. Zero. Why is lead bad? It's a neurotoxin. So what does that mean? What does that do to kids and as they grow up? Impacts their development, impacts their cognition, impacts their behavior, and we can treat lead, right? No, it's an irreversible, potent neurotoxin that has no safe level. So what we're supposed to do with lead is something called primary prevention, which in public health means we're never supposed to expose kids to lead. Are kids still exposed to lead today? Yeah, where are they exposed to lead in? You guys are great. Those is good audience participation. You're so fine. You guys are like good. Okay. So I heard paint. So yes, especially in older homes, underneath layers of paint, there's often paint that has lead in it. So we banned the use of lead in paint, but we never did it. We never funded the removal of that paint from homes. What do kids do when they see a paint chip?
They eat it, right? Why is it? That's how they explore the world motor activity. They put everything in their mouth.
And on top of that, lead paint is sweet. So it is like candy. So kids will eat it and they will eat it and they eat it and nobody knows and they'll have lead poisoning. Where else is lead in? Water, we'll get to that. Yeah, so what's the elemental symbol of lead? PPD, which comes from the Latin plumbum, which comes from plumbing. So lead was always in plumbing. You go to Pompeii and the kind of you can see lead pipes preserved. There's actually theories that hypothesize the demise of the Romans was because they used so much lead in plumbing, but they also use it as a salt in their food. So bad ideas. Okay, so we put lead in paint even when we knew it was bad. We put lead in gasoline even when we knew it was bad. What else did we put lead in? Oh, I just decided to give it away. Gasoline. We put lead in gasoline. Paint, a big one. Plumbing, a big one. Gasoline was a huge one. We put lead in gasoline. And hopefully we'll get to this part. I talk about this in the book because one of my favorite parts of the book. I talk about one of my heroes, Alice Hamilton. Who knows about Alice Hamilton? She was in Boston. This is why she should be your favorite Boston heroine. She was the very first woman professor at Harvard. First woman professor. But she, as a woman professor, was not allowed to go to football games. Like, who cares? So it was okay. She couldn't go to the faculty club, and she was not allowed to march in commencement because she was a woman professor. A few years ago, I did the commencement address at Harvard Medical School, and I had all the women faculty stand up in honor of Alice Hamilton. But anyways, Alice Hamilton was the mother of the field of occupational medicine, and she, in the 1920s, said lead was a poison. She's like, lead is such a poison. But General Motors was like, no, we're going to put it in gasoline because it fixes a problem called engine knocking, which is when fuel and air mix. And like, there's nothing else. There's no alternative. Lead is a gift from God. They actually said that. And she's like, no, it's not. It is a poison. You're going to create a global public health disaster. And they said, you're hysterical and that you should go back to knitting socks. So she was right. So we put lead, not we, evil industry put lead in gasoline, and it created a global public health disaster. I don't even know how we digress, but we put lead in a lot of stuff, but we never removed it from those things. We may have restricted its use, but it still continues to disproportionately impact the cognition and the development and the lives and the futures and the what do you want to be when you grow up of so many children. Lead is also a form of environmental racism, just like so many environmental injustices where the burden is disproportionately borne by our most vulnerable children, children of color and poor children. So I heard there was lead in the water, and I did the research, and I shared that research. I'm like, why isn't anybody listening to me, right? Like, why? Like, I stopped sleeping when I heard there was lead in the water. It's a poison, it's a neurotoxin. We just talked about it. There's no safe level of lead at all. There's no treatment. Yet it was in our drinking water system for about a year and a half. And there was roadblocks in every corner. People didn't want to hear me. They wanted me to close my mouth. They said I was causing near hysteria, which is also that sexist word, which has been thrown against so many women over time. And it was hard. And I talk about this in the book, and one of the reasons I wrote the book in the first person was so that you could be in my shoes and that you could go through that roller coaster of ups and downs. The heartbreak, the anger, the anxiety, the depression, the fear that I was going through, doing this research, asking the question, doing the research, seeing the results, not wanting my hypothesis to be true, but common sense, it was true, sharing this work, and then being attacked after sharing this work. So once again, roadblocks every way. And for a minute, especially after the government said I was wrong after I shared this research, and belittled me and belittled the science. For a minute, like I second guessed myself. I'm like, maybe I shouldn't have been doing this work. Like maybe I'm not an expert. There was also that sense of imposter syndrome that we hear about a lot. Like maybe like I'm not an expert. Maybe somebody else should have done this. Like I'm not the health department. Like this isn't my job. I was scared. My heart rate was up. And who am I? Like, I'm like literally barely 5 foot tall, like a brown, first generation immigrant woman, like going against some of the most powerful forces in the country, telling them that they're wrong. So it was hard not to feel defeated and tiny. And this is where I get to the point of the story. So all of us in this room are in this room because we care about people, right? You have all chosen professions that are about people. You didn't sign up to do this work for the power or the privilege or the prestige. You are here because of this great privilege that we have to care for people. And for me, it was the quick recognition that these attacks, these roadblocks, they had nothing to do with me. Like, they can go after Mona all they wanted, but this had everything to do with my patients. And my patients are kids. My patients are kiddos. And yes, my work was based on research, which was numbers and statistics, but every single number represented a child. And maybe a kid I've seen or cared for, like in like last year or so. And it was those kids that kind of lifted me up and enabled me to persevere and overcome those roadblocks. So you will have good days and you will have bad days in your career. And I want you to keep asking yourselves why. Like, why am I doing this? Why am I here? And I hope that your North Star, your why, I hope that answer is always the people, right? The people that we in this amazing profession, health and healthcare and public health, that we are privileged to serve. So don't ever forget that.
Wow, thank you. You answered a question that I had related to being called hysterical. And I just sort of want to bring that up again. I'm going to shift and ask you another question, but just to sort of bring this point home, that you encountered a lot of roadblocks, and maybe related to gender, maybe related to race, maybe related to lots of different things, right? Immigration, any and all things. And it's not lost on me that the word hysteria was used as a diagnosis for women for centuries. And in fact, I was just looking it up the other day and preparing for this, and there was a news article from a month or so ago about how women were talked about how their male physicians refer to them as hysterical. So this is something that we see that's pervasive in medicine, and it's really important that we understand it, but also really work against it, because otherwise, really important people aren't going to be getting their voices heard. All right, so to shift a little bit, so you describe yourself as the last piece in the puzzle in exposing the Flint water crisis, and there were you were sort of, the final link. And I want to ask you about the importance of coalition building in your advocacy, particularly across political lines. So one of the people you work most closely with was Mark Edwards, who you described himself as a conservative Republican. And you were quite candid about your own more progressive leanings and beliefs. But you both really needed one another to address Flint's water crisis. Can you talk about how you and Mark came to be such close allies and what you've learned about coalition building from this experience?
That is a great question. That is definitely kind of one of the themes of the story that I hope to share, is the importance of teamwork. And it sounds really cheesy, but it's so important, and it's especially important for those of us in medicine and health. I think before all this, as an academic pediatrician, I was a residency director, faculty person, a practicing pediatrician. I used to think that pediatricians had a monopoly on caring for children. Then I used to think there's nobody else that cares about kids more than we care about kids. And it was so wrong. It was absolutely so wrong, because gosh, engineers care about kids, and social workers care about kids, and lawyers do, and teachers do, and all kinds of folks also care about the same thing that you care about. And I think that is one of the most important lessons that I learned, is the importance of working with all kinds of folks from all kinds of backgrounds and disciplines and sectors who care about the same thing that I care about. So my best friend in this work was a water engineer. I never would have thought, my best friend in covering this work and leading the recovery would be an engineer. And he cared about kids everywhere. He wanted to make sure that kids everywhere were getting safe drinking water. So I think this is just, it's just critical in all of our work moving forward. So now, like in the recovery work that I lead, I have geographers on my team, and I have social workers, and I have psychologists, and I have all kinds of folks from all these different disciplines and different backgrounds. And when we're in a room together, we come up with different questions, and we come up with different answers, and it's absolutely beautiful. And I want to add the most important part of our coalition are the community members. So Flint's story, like in so many kind of health inequity stories, is a story where the people weren't listened to. Flint's people were especially not listened to because we had lost democracy. The city was taken over by emergency managers. It was a power grab. It was racially driven. And our elected officials actually had no power, our local elected officials. The state was running the city. And so even though moms were coming and saying, hey, like brown water is coming out of my tap, or my kid's getting sick, they were being dismissed and denied. When one of the emergency managers was subpoenaed to testify after the water crisis was uncovered, the head of the oversight committee, the congressional oversight committee, asked him, like, why didn't you listen to the people of Flint? Like, they were coming to you and telling you something was wrong. And his response was something like, I didn't have to. So let this kind of be a lesson of what happens when we corrode democracy. And this was kind of a weird situation, but it's no different than things like voter suppression or gerrymandering or mass incarceration. All of these things are also efforts that take away people's voices from the table. So as we kind of leaned into recovery, the central kind of tenet of this work was participatory democracy, was self-determination, was making sure that our coalition was led by the impacted community. So in my team, I have a director of community engagement. So a person from Flint who's a part of my leadership, who help guide all of our work. I have a parent partner group, a group of parents that we have sat with for over 8 years now, who drive kind of the recovery work and what we should be doing. And then this is my favorite. I have a group of kids who tell us what we should be doing. They're called the Flint Youth Justice League, and they're like a badass group of kids, and they created a logo. They're all superheroes, and I can sit and listen, which is really hard because I love talking, but I just sit and listen to what they think is important. So shortly after Flint's water crisis, there was a water crisis very similar in Newark, New Jersey, and our Flint kids were Zooming with kids in Newark and telling them what a part per billion was and how to sample water and what to advocate for. And now in the work I'm doing now with infant poverty, we actually have convened a group of pregnant mothers who are helping us. So, guiding our coalitions, our diverse, multi-sector, multi-specialty coalitions really should also be the people that we are doing this work for, because it's really work that we should be doing with people.
And I think your point too about working with people, hearing from people to drive the work, and your access to people, being a clinician and being able to do the public health work and having some of those doors open. And sometimes if you're doing public health work, you might not have access to people in the same way, but then building the coalitions are going to be so critical to make sure that we're talking to the right people, because we can sit in our offices and design interventions or make decisions that may be completely off base. So we have to really work with people to understand what their needs are before we can.
Yeah, that is so true. And I think also people are not monolithic. Like, community is diverse. So, we talk with so many people, and sometimes we get even, opposing things that the community wants. So it's really important to also kind of respect the diversity that's within the community.
So at one point in the introduction of the book,
well, can I add one more thing? I totally forgot. Sorry. So you mentioned that was like the last piece of the puzzle. So like, throughout the Flint story, like there was moms raising their voices, and pastors and journalists and activists and water scientists were saying, my friend Mark Edwards was saying, hey, there's a lot of lead in the water, but they were all being dismissed and denied and attacked. And then I raised my hand and I shared the research, and I was also dismissed and attacked, but eventually the state conceded after the doctor raised her hand. So it shouldn't have been that way. I should not have been the last piece in the puzzle. They should have listened to the first mom that said something was wrong. But let this also be a lesson on the power that you have and that your voice has in community. When the doctor with a long white coat with all these degrees after her name stood up, change finally happened. So use your powerful voice. Your voice is so powerful in community. Doctors and healthcare professionals, public health people, you have a lot of weight, a lot of gravity. People will listen to you. So do not be hesitant to use your voice and to partner with communities on these kinds of issues.
That's such an incredible point. Thank you. So, in your book, at the beginning, you say that this is a story about what happens when the very people responsible for keeping us safe care more about money and power than they care about us and our children. And as a parallel in my work in the field of substance use and addiction, I see many parallels between assurances made by the government that drinking water in Flint was safe and assurances made by Purdue Pharma that OxyContin was safe. And that's really hard, right? This really just erodes our trust in institutions, particularly ones that are very powerful, and we think, oh, we need to trust them. I mean, you talked about this in the book where people were raising their last drinking it on camera, and right? So to bring trust into the homes of people who had babies and who had children who were drinking the water. And so sometimes distrust is warranted. And there are times when distrust, like for example, vaccines, is not and can have negative public health consequences. So my question is, how can we rebuild trust with institutions that have betrayed us? And how can you build that trust with your patients and the larger society?
Oh, that's a ginormous question. I'm so sorry. I actually went to a conference of philosophers on this question of trust, and I'm going to steal their answer. And the philosopher said that we should always have a healthy dose of mistrust. I was trusting in the beginning of the water crisis. For a year and a half, my patients were coming to me with concerns. Should I, give my kid water instead of pop, a sugar sweetened beverage? Of course, we have a child obesity epidemic. Water is out there. Should I mix my baby's formula in this water? Because how do we make formula? We mix powder with water. And I'm like, of course, like how can our water not be okay? I bathe my baby and the baby always gets a rash to the water line. Is that okay? I'm like, yeah, it's okay. So for a year and a half, I was trusting because everybody in charge, all the government officials, everybody was saying everything was okay. And how can it not be okay, right? This is hello, we're in America, the richest country in the history of the world. Any Michiganders in the audience? Just yeah, hold up your hand, where you're from, point to where you're from, so Detroit. Okay, so this is what we do in Michigan. We hold up our hand, okay, because we're the Mitten State, because we're surrounded by what? The Great Lakes, right? The largest source of fresh water in the world. Oh my God, I heard you right. The largest source of fresh water in the world. 21% of the fresh water in the world is around Michigan. And here's Flint, a little south of Saginaw. Here's Flint, a little north of Detroit, Ann Arbor, the Atlantic, whatever. Okay, here's Flint, kind of in the middle of the largest source of fresh water in the world. So I was reassuring my patients because of it's America, we're in the middle of the Great Lakes, but also I kept thinking there's got to be rules and laws, right? There's rules and laws, and there's this social contract, right? There's this relationship that we have with government, and we pay taxes to make sure, no matter where we live, in Boston or Flint or Detroit, that when we turn on our water, right, our water is safe to drink. That is what I thought, and I wasn't super naive, okay? But that's not true. That is not true. The more I came to learn about, especially environmental protections and public health protections, the more I came to learn that our protections are grossly inadequate. And I think that's something we probably all learned during COVID as well. But when it comes to environmental regulations, we have really kind of been manipulated by special interests over time. And for when it comes to water, it's in the water industry, but so many industries over time that have made it so difficult to keep people safe. I'm going to go back to my best friend, Alice Hamilton, for a little bit. So when General Motors in the 1920s wanted to put lead in gasoline, she's like, no, 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 you can't do this. Remember, you're going to create a global public health disaster. So General Motors, like lead scientist, this guy named Robert Kehoe said, he made a deal. They made a deal with the Surgeon General at the time, and it said, if you can prove lead is bad, we'll take it out of gasoline. And that set forth something called the Kehoe paradigm, which persists to this day, where we assume poisons and chemicals and toxins are safe until proven dangerous. This is not the criminal justice system, okay? These are poisons. So that philosophy, that practice, has allowed for the unchecked use of so much badness. And then amazing scientists and activists, and moms and dads and journalists prove things are unsafe, like lead. You know, probably the most well-studied neurotoxin now. We prove it's unsafe, but it's impossible to undo the damage that has been done, and it's impossible to regulate to this day. So that's why we continue to have all these bad things in our environment, and the list goes on of things that we don't even know about, like the forever chemicals that we don't even test for, and the list goes on, because of these grossly inadequate protections that we have in place. So it's important to understand kind of that why. There's a great book called Triumph of Doubt by David Michaels, who's at George Washington. He was the former director of OSHA, who studies kind of this playbook that has been used by industry over like a century that has instilled doubt in science, that even has come up with like fake journals, that attack scientists, that does all this secondary data analysis for the primary goal of making profit and weakening regulations. So we should not assume the food that we eat or the air that we breathe or the water that we drink is totally safe. Everything has risks. But we should also not live in paranoia because that's like unsustainable. But we should learn how to, reduce exposures. But the answer, which is harder today, the answer is strengthening regulations, making sure that no matter where we live, we can turn on, for example, a tap and ensure that our water is safe. And great strides have happened since Flint. In the last few months, just a couple months ago, President Biden was in Milwaukee, and the lead and copper rule, which is at the crux of the story, was finally improved after 30 years, mandating lead pipes are replaced across the country over the next 10 years, improving sampling, doing inventory. That's primary prevention. The Infrastructure Act, which passed a couple of years ago, which was helped make happen, included billions of dollars to replace lead pipes across the country. That's primary prevention. These are the kinds of things that we need to do to make sure that we can have trust, that we can have that renewed faith in government to make sure that no matter where we are protected. Thank you.
So you say in the book, a crisis is a terrible thing to waste. And you surely did not waste this one, being able to turn it into hope and justice and healing. And in fact, the subtitle of your book is A Story of Crisis, Resistance, and Hope in an American City. And holding on to that last piece of hope, because if we take the story, which is devastating at the beginning, and it's still devastating because we know what this means for future, and yet we do need to hold on to the hope because this is something that you were able to really become very important and have a name around what this means for not just Flint, but the whole country and maybe even beyond. And you were able to create a model program, a public health program of family support, home visits, early education, school health services, nutrition, health care access, and more. The list goes on. And on top of it all, RX Kids, which is a maternal and infant cash prescription program, a cash prescription program, for those of you who haven't heard about it, for Flint residents, which is the first in its nation. You helped establish and you direct this program, which was launched earlier this year. In approximately 9 months, RX Kids has prescribed over $4 million in cash to over 1,000 families. Can you tell us a little bit more about these programs and how Flint kids are doing now, and all as we think about hope and as we end our?
Yeah, Margie, I would love to. So I absolutely want you to go away with what she just mentioned. So yes, the story is like totally a terrible crime, like literally a crime that was committed against some of the most vulnerable people in our country. But more than that it is this amazing story of fighting back, right? It is a story of medicine walking outside of our classroom doors, our hospital doors, our clinic doors, raising our voices, working hand in hand with communities to refuse the status quo, right? So this is a story, this is a playbook of resistance. Once again, of how to fight back and how to bring real tangible hope to communities who've lost trust and faith in institutions and government for a long time. So we've been able to put into place a lot of good stuff, a lot of secondary prevention, a lot of things to mitigate the impact of the crisis. A lot of this is weaved together by something called the Flint Registry, which gets people connected to these resources that we talked about. But most excitedly, we are trying to go even more upstream. So we have brand new early child care programs and home visiting programs and trauma-informed care and neurodevelopmental assessments, all these good things that we ask families to do to help with the situations of the children and families. And it's kind of annoying because we keep asking families who've been oppressed to do more. And a recent article I wrote for the New York Times was, I'm sick of asking children to be resilient. I'm sick of asking kids who by no fault of their own were born in a zip code that makes it near impossible to grow up to be healthy and successful to do more. So that's how our kids was born. It was this impossible effort to treat a root cause issue of inequity. And that's poverty. And for so long as like a practicing pediatrician, like I have wished for the ability to like prescribe an antidote to poverty. Because so much of what we see in our patients are because of things like housing instability and transportation issues and food insecurity, missed appointments because of all these different reasons. Poverty is a root social determinant of health. But we've shrugged our shoulders, like, we can't do anything with poverty. Like, how are we gonna fix poverty? Like, I'm just one doctor in one clinic. Like, how am I gonna fix poverty? But then we did something amazing in 2021. Do you guys know what we did in 2021 to fix child poverty as a nation? So it was during COVID. So COVID sucked, but we actually did some really good things for people. We expanded the child tax credit. And that pretty much gave almost all families with children unconditional child cash allowances. And we dropped child poverty to its lowest level ever recorded, to about 5% in this country. And with that, we improved nutrition security and housing stability and improved health outcomes. And there was less abuse and neglect and less debt. All these amazing things happened. And then it was not renewed by one vote in the US Senate. And poverty went back up again, and all those bad measures went back up. But that created this moment, like, oh my gosh, we can do hard things. We can be like almost every other Western country that has child cash allowances. And so that really kind of created this impetus for doing something that hasn't been done before. So RxKids is at every pregnant mom in Flint gets $1,500 in mid-pregnancy. And then every baby gets $6,000 in their first year of life, distributed as $500 a month for the first 12 months. It is universal, which conveys dignity, conveys this is how we're supposed to take care of each other, that it's hard for everybody to raise a family. And the unconditionality, no strings attached, conveys trust, which is something we're not used to in our social programs. We don't trust mamas. Especially Black mamas. So the program launched, I wrote a grant to launch this. My university had like a big idea for health equity. Like, what is like one thing you do to improve health? I'm like, I want to do a child allowance program in Flint. And they're like, no budget, like what would you do? And I got rejected. And I'm like, what? And I read the reviews, they're like, this is a good idea, but it's not feasible. So I swore, and I'm like, F you, I'm doing this. So then I wrote another grant to the NIH, and they had this big, like, common fund application, like, what would you do to address, like, a root social determinant of health? And I'm like, I want to do this thing in Flint. And I got rejected. And I'm like, oh my God, but this is such a good idea. My former chair said she could line her office wallpaper with rejections, of grant rejections. So I persisted. So I'm like, and I made friends and I brought in allies. We have now raised over $100 million for this program in less than 2 years. It is a public-private partnership. We also leverage money from the state of Michigan, ARPA dollars, foundation dollars, funds from all over. Like Margie said, we've prescribed over $4 million to over 1,000 mamas and babies. We are on track to eliminating deep infant poverty in the poorest city in the nation. And everybody said you couldn't do it. And we did it. All right, we did it because of my new best friend is like a child poverty expert, like who knew, just like this engineer. And we made friends with all kinds of people to make this impossible possible. Just like we refused to accept poisoned water in Flint, we have refused to accept babies growing up in poverty, which is a pathogen, it's a toxin. You don't have to be okay with it. So the governor of Michigan added $20 million in our last budget. We're expanding the program to other low-income communities in Michigan. It's a place-based intervention. If you recall some of the language during the election, Vice President Harris actually adopted our $6,000 newborn credit in her policy proposal, but we still have that as a bill in the expanded child tax credit legislation, which is still in Congress. So we're excited to kind of share this intervention, this very, really simple, common sense intervention that addresses the poorest time in people's lives, when child development is the most critical. Once again, another thing that was led by medicine and healthcare or prescription to tackle a root cause issue, because we don't have to be okay with how things are today.
Yes, and that is such an incredible example of the intersection that we were talking about earlier, medicine, public health advocacy, policy, all of those things with really hope on top, right?
It's joyful. It's also like the framing of it is full of joy. We launched the program on Valentine's Day because it's about love. It really is about love. It's about how we love our babies. And it's about freedom and choice and agency and autonomy and all these important themes and values that should be part of all of our work.
Thank you so much. We are going to open this to the audience and see what kind of questions we have. You want to raise your hand? I think we're going to bring, people will bring microphones around. Thank you. And can you state your name and what program you're in? And if you're from Michigan. And you're
from Michigan. Hi, I'm Harrison. I'm a first year medical student on the main track here. And thank you so much for coming, Dr. Mott, first of all. I'm hoping to ask you about a water crisis that's in my home state of Maine, that's actually in the Passamaquoddy tribe in the eastern part of the state. It's a similar issue sort of to Flint in that there is no elected officials and indigenous tribes in Maine don't have the same representation as other tribes across the nation. And I'm wondering how we can advocate for the Passamaquoddy tribe as the state of Maine continues to deny them full sovereignty.
Oh, that's a good question. So there's lots of water crises that are happening right now. Syracuse, New York is in the midst of a water crisis right now, a lead water crisis where we're also denying that there's an issue, and the water levels there are actually kind of even higher than in Flint. So the lack of representation, the environmental injustice, this a community of color that has historically been disenfranchised. If you think about water, water is a public health and a medical necessity. We cannot survive without water. When the water crisis happened in Flint, and once again, Flint was in crisis for decades, also a community that has suffered from really kind of disinvestment and racial and systemic inequities. When the water crisis happened in Flint, there were some people in Flint that said they thought it was purposeful. Like, look, it's a genocide. They're finally trying to get rid of us. And I can see some resonance there where the people in this community, the Native Indigenous community, feel ignored, that this is another effort that they're trying to get rid of us, right? That they're not listening to us, they're not valuing our lives, that our lives don't matter, right? So I think what we can all do, just like what you're doing, is raising attention. The book is called What the Eyes Don't See because it's about seeing. So now I see. I didn't know about this thing in Maine. Now I know about this thing in Maine. Now you all know about this thing in Maine. So you can pay attention to it. You can support local journalists who are trying to cover the story. You can subscribe to your local papers. You can go out and listen. Don't go in with answers. Hi, I'm from Tufts Medical School. I have all the answers. No, that's not what you're supposed to do. Like, hi, I'm here to listen to you. How can I be helpful? What can I bring to your community? Would you like me to write an opinion letter for the newspaper? Do you need help with science or citizen science? So humbly working once again with communities, not thinking that you have all the answers. Bringing in resources from your amazing institution, like, hey, I can maybe get a hold of water people from my institution or other kind of organizers that can help address this issue. So there's a lot that we can do, even though that we're far away.
Hi, Chaz Hanna. I'm a general pediatrician here, and it's a pleasure to meet you. And I hope for we are the best. I'll say you're passionate and palpable, and I love that. Favorite color of rainbows is kind of the trend of the year here for me. Also on the side, nice to hear somebody say the word pop and some soda. I'm from upstate New York, grew up in Lake Erie, where also the water has not historically been the best thing to be drinking, and I think
you turned out okay.
I think so, at least.
What could you have been?
My question for you is more for the kind of lens of learners, kind of thinking about how you can bring the passion that you've demonstrated, the advocacy that you have when, as students are in their clinical times, they then transition to residency. How do you keep sight of that advocacy work, especially as the pressures are mounting with just the high level of knowledge we have now for students to understand, the complex systems they need to navigate, the really tumultuous democratic system now that we'll be entering in the next couple of years that I think a lot of us really are fearful about. How do you kind of give advice to students or to residents to say, this is one way that you can keep that sight of line while still focusing on everything else?
That's a great question by my fellow pediatrician. So smart, right? You're just so I was with med students all day yesterday and with residents, so it's still very much one of my most prominent hats as a medical educator. And I love hanging out with you guys because you care so much. You care about so many different things, and you are leading so many of the movements that are so important right now. And you are also leading so much of the change that needs to happen in medical education that is embedding things like public health and environmental health and all these things, advocacy into your curricula. But because you care so much, I often see a lot of burnout, like because you care so much. And I have these kind of tips that I like to share kind of with my students and residents. And the first one is to like find your thing, like find your passion. Like what is like one thing that like I know you care about a lot of things. You know, you guys could like go on a march every weekend, but like what is like the one, it's good over, but it's hard. What is like the one thing you care about? Is it women's reproductive rights, right? Is it the effect of climate change on health? Is it environmental health? Is it, what is, find your thing, okay? Find your one thing that you care about, your passion, okay? And then after that, find your people, okay? So we just talked, my work was not solitary work. It was done with other people. You need people in this advocacy passion work because it is hard. It is exhausting. You need to be there to lift them up and you need them to be there to lift you up. So find your peeps, and remember your people might not be in medicine. They might be out in the community or they might be in different disciplines, but find your people. So find your passion, find your people. And my next P is be prepared. So doing things like this is preparing you for potential work in advocacy. If your institution or an allied group organization has something like advocacy training or media training, So raise your hand and say, okay, I'll try that. I'm gonna do that. So when I was a resident, like part of my professionalization was meeting with legislators. We had something called Advocacy Day, where we would like think about like pick a bill that was in our state legislature, and we would create little fact sheets, one pagers, small words. But before we would go to our state capitol, we would do role playing to pretend to practice how to talk to legislators, just like how we do role playing giving bad news and how we do simulations. So we also have to do that practice work to be advocates. So to take, those things might be like the first time I was a resident, and there was like someone like the hospital was like, we need somebody to go on local TV to talk about the importance of back to school vaccines. And I'm like, I'll do it. I had never done anything like that before. And it was a terrible interview. I said it all like 100 times. It was so bad. But you know what? My last interviews were a lot better. So having practice in this kind of work is important. We just created a program in my initiative called the Alice Hamilton Scholar Program. So it is a post-residency fellowship where folks get advocacy training. They're embedded and they learn how to review bills and talk to legislators. And they get, they do research and they're clinicians. But these things are not innate. You can't just put a doctor in front of a TV or a journalist or a policymaker. You have to practice these skills, okay? So find your passion. Find your people, and your people are also your mentors who are have multiple mentors. There's no rule that you only need one mentor, and mentors can be anywhere. People email me all the time. I've never met them, and I respond to their emails. It's okay. Feel free to email me. Not all of you, but so find your passion, find your people to support you and you support them, and be prepared to do this advocacy work. The last thing I tell my students and my residents is you have to get through this. You have to be a doctor so that you can go on and advocate as a doctor later. So sometimes the advocacy work has to take a little pause so you can get through your shelf exams, so you can get through your rotations, and you can do everything. It doesn't have to go away completely, but it's part of kind of that you'll get to do that later on, but you have to get through the slog that you're in right now too. Nobody likes to hear that.
And we are about time. Are you okay for one more question?
Yeah, one more question. Sorry. Thanks so much.
We love it.
I love you.
So hardly they have to pick the one last person.
Oh my God, we'll do two.
Okay. We'll do two, and if people have to leave, you won't be offended, right? I mean, highly offended?
That's totally offended.
Hi, Dr. Mona. Thank you so much for being here, for all the work that you do. It's really a privilege to hear from you. My name is Alyssa. I'm a first year in the MD and PH program. So in your book, you describe seeing Flint infants and kids such as Nakala and Reva during a period in which they were exposed to lead in the water during a critical period of their development. How do you continue to see these kids, and if so, how have they been doing?
That is a great question. So yeah, I continue to see these patients that were impacted by the water crisis. But you don't want to know how the patient I saw yesterday in clinic is doing. You want to know how the population of patients are doing. That's that surveillance. And that's why we set up the Flint registry, which tries to answer that question, how are people doing? We've been able to enroll voluntarily over 20,000 people, adults and children. And by and large, there's issues, there's challenges, be it with cognition, behavior, all kinds of issues. Is it because of the water crisis? I don't know. It wasn't my goal to prove causation. It's my goal to get them into support services. But our kids have higher rates of behavior issues and ADHD, lots of things that are correlated with lead, but also lots of things that are correlated with all the other adversities and toxicities of what it means to grow up in a place that's really poor.
I think we have one last question over there.
I'll also answer your questions at the reception. I heard there's amazing food.
And even though this is the last question, no pressure.
It's gonna be amazing.
Very much. Hi, Dr. Mona. Thank you so much for talking. My name is Dan. I'm a first year medical student. I wish I was in the MDMPH. I majored in community health though.
Yeah.
But I'm kind of concerned about two impending water crises kind of with this new administration. One, there's two, many. I think there's a lot of rhetoric with this new administration about removing fluoride from water. And two, I think there's a lot of concern about what global water access will look like with the US kind of talking about removing a lot of funding from USAID and a lot of other global health agencies from the government. And so I'm really frustrated about this. And so I guess kind of related to your question, I am trying to find like very tangible actions that I can do, given like my bandwidth and energy as a med student. So I know you were talking about actions like writing op-eds and contacting our local legislators. Do you have any other recommendations for very tangible, not very time consuming ways to address these injustices?
That was a good question. Good job.
Vote in 2 years, okay, so that's really important. Yeah, that's a tough one. So, you have an answer?
Yeah.
Yeah, well, go ahead.
Hi, I'm John Rumpler. I'm a Tufts alum, and I'm not a doctor. I'm one of your allies. I'm a lawyer.
Yes,
I work for Environment America, and our state affiliate here is Environment Massachusetts. Modeled on what we won in Michigan, we now have bills in the Massachusetts legislature to prevent lead contamination of schools' water.
Yeah.
So if you want to take an easy action,
Yeah.
get onto the Environment Massachusetts email list. We'll send you a petition that you can sign. It'll take 30 seconds.
Yeah, lawyers are our friends right now, be it from the ACLU or the NRDC or other local organizations. Journalists are also our friends. We need, once again, subscribe to papers, support journalists. We need to see these.
And for all of you first years in here, please know that in January and February, you will have the opportunity to do your own individual advocacy assignment.
Oh my God.
For which you will get credit in addition to doing amazing advocacy of your choice on a topic that you want. So stay tuned.
Yeah, it doesn't have to be big. It could be like the food in your cafeteria. It could be something that you do. The advocacy doesn't have to be like ending the water crisis in the city. It could be littler things. Those are all individual encounters that you have with your patients. Is advocacy. That's all important. It's all the things go things.
And speaking of ending on a note of hope,
Yes.
Dr. Mona, thank you so much for being here and for really just sharing everything that you did. Incredible work that you've done and continue to do. Thank you so much.
Thank you. We will have reception.